Okay, now we're recording successfully. Okay, so this is our second session on lymphomas, and we're going to cover some of the basic principles. So for this first one, are we deep or are we top half of the dermis? We're top half and broad and band-like, right? Which is a T pattern, whereas B patterns tend to be deep nodules. So that's number one. T lymphomas are commonly follicular tropic or into the sweat ducts as well. When they're into the sweat glands, you can get really tibia of the sweat glands where it can mimic eccrine carcinoma. So you have to be aware of that. B things tend to be heavy and deep. Leukemias pick up T markers. So one of the hints to leukemia is it's CD4 positive, but CD3 negative. That's a hint to leukemia. So it's 4 positive, 3 negative, think myeloid leukemia when you see that. That includes the type that's now split out of the leukemias again, the blastic plasmacytoid dendritic cell neoplasm. In contrast, is this a superficial band, or does this relatively spare the epidermis and instead is a very bottom-heavy nodular infiltrate? This is more of a B pattern. Right? And then of the once you're in the world of B, you're looking at, is it a blastic lymphoma or not a blastic lymphoma? Blasts are round. So sites, like centrocyte, is cleaved like the letter C, site, C, cleaved like the letter C. Blasts are round. Blasts are more primitive cells. A cleaved B lymphoma is better differentiated and usually more indolent than a blastic B lymphoma would be. A immunoblast, the nucleolus is central. Centroblast, it's peripheral. Immunoblast is a little more poorly differentiated still than a centroblast. So as you go better differentiated, it's immunoblast, centroblast, centrocyte. Centrocyte has the peripheral nucleolus and a cleaved nucleus. The other thing you're going to do is you're going to look at how it stains. Is it a marginal zone type population or a follicular center type population? That does have implication for how it behaves. What doesn't have implication is if it's a primary cutaneous follicle center lymphoma, it doesn't matter if it's diffuse or if it's follicular pattern. Those behave the same. Some of the translocations, like 1618 translocations, you can do by fish, and you'll see us do those in the lab. So, this you'd think it's probably B, and then you're going to look higher, and you see some mitotic figures, not a huge number of mitotic figures. What has the higher proliferative rate? A benign germinal center or a lymphoma? It's the benign germinal center by far that has the higher proliferative rate. So why doesn't it expand and kill you? Because they're tingible bodies. There's programmed cell death. So programmed cell death means the cells they undergo an orderly death, at a rate that equals the mitotic rate, right, and the proliferative rate. In lymphoma, it's not so much that they are dividing more, it's that they're failing to die on cue. And you look for things like the tingible body macrophages, which are the debris of the dying lymphocytes taken up by macrophages in the lymph node or skin. And you look also for things like BCL2, which, when it's expressed in a follicle center population, protects against programmed cell death. So BCL2 expression you're supposed to see in marginal zone cells. You're supposed to see in systemic lymphomas. It's very common. It's present in 20% of primary cutaneous marginal zone lymphomas, and it does correlate with how it translates to the behavior of the lymphoma as it protects against apoptosis. So if you look at these cells, most of them are not cleaved cells. They're round. A lot of them don't have really prominent nucleoli. Nucleoli that are present, a lot of them are peripheral, so there are a lot of centroblasts. But it is a somewhat blastic lymphoma. Blastic lymphomas that are on the leg and pick up MUM1 tend to be 95-year-old women and are much more aggressive. In general, blastic lymphomas are more aggressive anyway. Right? And for all of them, you're going to stage them. So when you see a BCL2 positive follicle center lymphoma, it's 20% of those are still cutaneous, right? Primary cutaneous, not systemic, but everyone's got to be staged. So that part doesn't matter as much. Here we've got something that you can see. First off, papillodermal fibrosis, and you have lymphocytes in tiny little vacuoles between that ropey collagen. So sits like a lump of coal on a pillow between dense ropey collagen. That's virtually always a T-cell lymphoma pattern. You've got papillodermal fibrosis, and intercalated between those horizontally oriented, dense, hyalinized collagen fibers are T cells, and often they line up in rows and they sit in little vacuoles like lumps of coal on a pillow. In this particular case, when you look at the T cells, they're not nearly as hyperchromatic and convoluted as MF tends to be. MF, they tend to be really black cells with notches in them. These are not quite as notched and not quite as dark, which is sometimes a clue to downgrading of MF, but also can be a clue to adult T-cell lymphoma leukemia, HTLV1 disease, which occurs in Japan and other parts of Asia and occurs a lot in the Caribbean. And in the U.S., you see it in Afro-Caribbean populations. So populations have shifted around New York, but when I got to New York about 10 years ago, Colombia was seeing tons of it. I mean, they practice in Spanish Harlem, big Dominican population. Downstate, hadn't seen it yet. Now they see plenty. So it's merged as populations shift, but it was very much an Afro-Caribbean type of lymphoma when we would see it, or occasionally Asian patients with the HTLV1 disease. They often also have chronic refractory dermatitis. So if you were on the far upper west side of New York and you had someone with a chronic itchy dermatitis out of nowhere as an adult, one of the things you look for is HTLV1 disease. It's probably not inappropriate to think of that, especially in any Afro-Caribbean population where you have someone with a chronic refractory dermatitis. This is, you can see someone's burnt the snot out of this slide. You can see there's still epidermotropism. So this was MF. But again, just like in the last slide, these cells, they're not so... You have some very dark crenated slides that look like shriveled raisins where you can see the notches in them. But you have lots more cells that are getting blastic. Blastic transformation in a T-cell lymphoma is pretty bad. Right? That's usually a terminal event. They're often CD30 positive, and so you have brentuximab that you can use that targets CD30, and that has really changed outcome. Some of them still respond to megamolizumab infusions. So we have people that we follow who are now 10 years into their blastic nodular transformation of their MF and still perking along because we have new things to offer them. So here we have a fairly diffuse pattern of cells. And the first thing is, do the cells vary much, or are they pretty monotonous all the way across the field? It's just sheets of very monotonous lymphocytes, right? That's concerning for lymphoma. And then you're going to look to see, what kind of lymphoma. One of the clues also to lymphoma, a couple of clues. One is the knife shatter that you get, almost like a Venetian blind, because lymphomas are cheesy. So when the blade cuts through it, you get that, it's not a clean cut. You get knife shatter along it. This kind of clefting goes along with that. That's a manifestation. There are also all of these squashed lymphocytes. Sometimes they're called carrot cells, or in Europe they call them spermatozoa-like lymphocytes, just meaning they're long and skinny. Right? Just means they've been squashed. Right? They've been squashed by the surrounding cells. That's a weird morphology for a lymphocyte, and that commonly is a clue to lymphoma. So then once you get that far, is this a follicular pattern or a diffuse pattern? Diffuse, right? You're not seeing things that look like germinal centers with cells around them, right? One of the we'll get to marginal zone in a second, but let's finish this. So this is diffuse pattern. Diffuse patterns are commonly follicle center type phenotype when they're cutaneous. You're then going to look at markers, right? So CD20 positive, what does that mean? B cell. CD79A positive, what does that mean? B cell, and it begins earlier and stays later in the life of a B cell. So even plasma cells are CD79A positive, where they've lost CD20. So if you look at the life to death of a B cell. If this tube is the life of a B cell, CD20 is about the middle, whereas 79A goes from birth to grave of a B cell. So it's just a longer marker. There are other markers, PAX5 and others, that are also used as B cell markers. This one is BCL2 positive. What does that suggest? So marginal zone can do that, but it doesn't look, it's a big diffuse lymphoma. It doesn't look like a marginal zone. So that could be 20% of cutaneous, primary cutaneous, but the rest are systemic lymphomas. And this one proved to be a systemic lymphoma. BCL6, CD10 are also germinal center markers. CD10 is lost first. So if you're a really well-differentiated follicular B lymphoma, you tend to express both CD10 and BCL6. First thing to go is CD10. By the time you get to a blastic lymphoma, about half of them will still express BCL6. About half have lost that as well. They pick up things like MUM1 at that point. Your first inclination might be just write this off. Perivascular lymphoid infiltrate, kind of non-specific. If you look at the cells, though, see how they're kind of angulated? They're odd shapes, and they have a little rim of cytoplasm. Some of them are cleaved. That's not a normal peripheral lymphocyte. In this case, you stain them. They stain for CD4. They don't stain for CD3. And that angulation and the peripheral rim of cytoplasm are also clues that it's leukemia cutis. Right? So non-specific perivascular lymphoid infiltrate versus you have leukemia and you have myeloid leukemia, that's a bit of a difference, right? So look at the lymphs. This is, we're big pattern people. Go a little closer. Look at the lymphs. In this case, you have large hyperchromatic angulated cells with a rim of cytoplasm. That's a clue to leukemia. And then they stain with CD4 but not CD3. That's another clue to leukemia, and drives you to things like myeloperoxidase and other lysozyme, other markers that would help you with leukemia. Let's look at a couple more. So in this case, first thing that hits your eye is you got lots of necrosis, right? You've got dead vessels there. And when you look around the dead vessels, even though a lot of the cells are necrotic, you can see there is some big lymphocytes around those vessels. Angiodestructive, so angiocentric, angiodestructive lymphomas ulcerate and tissue necrosis. So the lymphocytes beat on the vessels, destroy the vessels, the lymphoma ulcerates. They can look like pyoderma gangrenosum. What used to be called lethal midline granuloma of the face, which is granular nasal type lymphoma, is also an angiocentric angiodestructive lymphoma. It ulcerates because it's killing vessels as it goes. So in general, they tend to be a fairly aggressive type of lymphoma. If they're CD30 positive, one, you've got another target. You can hit them with brentuximab. Two, they're sometimes more indolent. And 3, sometimes they look angiocentric, angiodestructive, CD30 positive, but they behave like lymphomatoid papulosis. And they're really a type of LYP. So those are all things to keep in mind. Fairly diffuse, not a follicular pattern. Actually, diffuse follicle center lymphomas are more common than the follicular ones in skin. You have, as you look around the cells, there are still some cleaved cells. They have they're not round, right? They have, sometimes you don't see a deep cleft, but you see that the cell is not round, right? It's got a kidney bean shape or something where it's trying to cleave. A lot of the nucleoli are peripheral as well as some central ones, so you have centrocytes, centroblasts in this lymphoma. Lymphomas often line up, so when you look at it, it looks almost like a jigsaw puzzle with lots of black cells kind of lining up in rows, sometimes in concentric rows. That's also a clue to lymphoma. And then you're going to go through your markers again. Let's get it. Again, you got something very patchy. So there could be a couple of things. If this is a Mohs case and you have dense lymphoid infiltrates that just won't go away, they just stay on forever, one of the possibilities is your patient has CLL. Vic Marks, great Mohs surgeon at Geisinger, would about twice a year pick up the phone and call the internist and say, "Are you aware your patient has CLL?" Half the time they were not aware their patient had CLL. But you can see it, just those dense B cell infiltrates that are CD5 positive, CD20 positive, that just don't go away and keep on going as you do the subsequent Mohs stages. So brings up the possibility of CLL or of other B lymphoma. Certainly not a follicular pattern in this case. You've got a lot of crush. That crush is also a hint to lymphoma. You have your collagen, coarse collagen bundles, and you can see how those lymphocytes are really densely intercalated between those collagen bundles, and then there's peripheral crush. That's a lymphoma pattern. And then your question would be advanced T or B lymphoma. Well, CD3, CD20 will answer that question typically. In this case, it's CD20 positive, so it's a B. The cells are pretty round. You have a lot of those spermatozoa or carrot-like crushed cells, again, clue to B lymphoma. T lymphomas don't tend to have those squashed carrot cells. And then it's round, so it's becoming blastic. So in this case, it was a peripheral or a systemic lymphoblastic leukemia. In your chapter reading, you have some great pictures of follicular B-cell lymphomas. Clue are that the follicles are not round. They have irregular shapes and mold against one another, similar to nuclei in a Zank smear. The mantle zone is not symmetrical. It's a crescent-shaped, discontinuous mantle zone. Here you've got big, round cells, lots of mitotic figures, lots of centrally placed nucleoli. This is a nasty blastic lymphoma. Sort of thing you might see on the leg of an older person. Probably last concept we want to hit is you stain this, you got a Grent zone. Well, that's not particularly T, right? T lymphomas tend to abut the epidermis like MF. Right? This has a bit of a Grent zone, a little more like a B lymphoma. But you stain it, these are all T cells, until you get to the larger cells in the center. So you can see sheets of these T cells that are smaller, darker cells, and then large groups of these larger gray cells in the center. Those large gray cells are B. The only clonality you're going to pick up is B. This is a T cell rich B lymphoma. Classic examples of that are lymphomatoid granulomatosis. T cells come in and destroy your lungs, but Mr. Big, who's calling all the shots behind the scenes, he's a B cell and getting his nasty T cell henchmen to do all the damage. Okay, those are T cell rich. It's a T cell infiltrate that often damages tissue but is driven by a clonal B cell population. Sometimes you have to ferret them out by which one has the clone and which one is the ugly cytologically population versus the one that is morphologically normal population. Okay, that's probably about as much as any of you can retain or stomach of lymphoma for a day. The markers are important. You know, you, in a general derm practice, you're probably not going to sign out a lot of lymphomas on your own. You certainly need to suspect lymphoma and know when to refer the case out and not read it yourself. But you will get reports, and the reports will have that alphabet soup of all the markers. They're trying to tell you something. Hopefully they will say it has blah, 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 that string of 20 markers, which means, and interpret it for you. But you do need some basic knowledge of what those markers translate to. So those are important. Okay, let's start into the fun stuff, which is potpourri. And then, after, I think we have one more metastases and simulants of metastasis chapter. Then we go into potpourri for the year. I would encourage you, there are also 4 summative exams that are put together that are reflective of what DermPath on a board exam might look like, that sit in boxes at the top there. They're the ones with the numeral 4. Those are put together specifically if you want to see how am I doing. Those have no labels on them. They are cases chosen as a great, if you want to test yourself to see how you are standing with DermPath, those are great ones to do as self-test. Okay. And then we're going to do lots of potpourri sessions for the remainder of the year. Okay. So, acral skin. So you see some hypergranulosis. I don't see particularly blue cells. Now the stain's a little on the eosine heavy side, but I don't see foamy blue cells like EDV. I do see significant hyperkeratosis, right? And the other thing that I see, although they're not many in number, what do you think about the size of the lymphocytes? They're pretty big, right? And they're sitting tagged at the DE junction. And then the next question you're going to ask is there papillodermal fibrosis? So do you see collagen bundles above the postcapillary venial? There should be none. In this case, I definitely see bundled ropey collagen above the postcapillary venial. So I have papillodermal fibrosis, and although they're not large in number, I have large lymphocytes sitting at the DE junction. Right, you can see for those on monitor, I just lost my pointer. Let's see if we can bring it back to life. There we go. Right there you can see large lymphocytes sitting at the DE junction, ropey collagen above the postcapillary venial, and this is, it's mycosis fungoides. Probably someone who's been under treatment so that all of the benign recruited lymphocytes are gone, and all that remains are those few big MF cells sitting tagging at the DE junction. Okay, that was probably a little bit hard, but reflective of real life. Okay.
So I see limbs deep in that coil, but I don't see like a lectin.
Yeah, so we see cells deep in the eccrine coil, and the question is, are they all lymphs?
There's a few like neutrophils.
There are neutrophils, so in fact a fair number of neutrophils. Yeah, and some of the cells that looked like they were lymphs actually are angulated and have a little rim of cytoplasm around them. So what kind of neutrophilic eccrine hidradenitis could this be?
Are you describing like a blast?
Yeah, probably in the setting of leukemia, right? And you've got some recruited atypical lymphocytes that you're seeing, or atypical, actually, myeloid cells with that rim of cytoplasm. So you're seeing some recruited atypical myeloid cells in the infiltrate as well as neutrophilic eccrine hidradenitis. So NEH comes in two main flavors: Pseudomonas hot foot in kids with sweaty sneakers, and leukemia associated, often in the setting of the chemotherapy, especially things like cytarabine, Ara-A. Often things that will also give you acral erythrodysesthesia can give you so toxic erythema of chemo can also give you neutrophilic eccrine hidradenitis.
I see edema and inflammation. Looks like granulomatous and suppurative.
Yeah, so suppurative and granulomatous, and it's kind of central. So what would be a central structure around which a suppurative and granulomatous process would occur in skin? Usually follicle, as you said. So suppurative and granulomatous folliculitis, often infectious, sometimes acne. Well done. It's large. It has cystic degeneration. Is there visible cytoplasm or no cytoplasm? Is there pink? There's pink, right? So there's cytoplasm. And what are all the little round white things? Duct. And there's no palisading. We may be a little scanning power for that, but take my word for it. There's no palisading. So there's no palisading, there's cystic degeneration, there's duct, there's visible cytoplasm.
It's definitely carcinoma.
And you have this osteoid-like stroma around vessels, so-called poromostroma, right? So it's going to fit into the acrospiroma group, solid and cystic poroma, nodular hydradenoma, clear cell hydradenoma. There are a million names for the acrospiromas. As you pointed out, though, there are areas that are pretty blue. So you want to look very carefully at that and consider a porocarcinoma, malignant acrospiroma, if you have areas that are pretty much all nucleus and have lost cytoplasm. This has pink areas. Benign acrospiroma would usually have about that much pink throughout the tumor. This one has a lot of blue. I'd be a little cautious about its potential because it has areas that have lost most of the cytoplasm. Well done. So you're in an area that has good amount of hair.
And then
How happy are those follicles?
not very happy. They look like they're kind of being attacked by lymphocytes.
What gives you follicular necrosis like that?
Zoster.
Yep. Well done. This is zoster. So sebaceous necrosis or follicular necrosis, think zoster. Well done. Someone passed that easy button there.
就是这么简单。
You can choose your language.
So there's some fat. It doesn't look
So unhappy
very
fat,
happy. Yeah.
right?
enough
Unhappy fat.
Oh, it's like lipomembranous change.
Lipomembranous change and cystic fat necrosis makes you think of
Oh, yes.
lipodermatosclerosis. Well done. Keep that easy button going. Choose a different language.
Passively.
So, looking up in the corneum, it's kind of abnormal.
So tell me about what's wrong with the corneum.
It's kind of flaking off.
Kind of flaking off. Also kind of a coarse basket weave. What do you think about the cells
It's like hyper.
around the granular layer?
Oh, the bluish hue, like EDV.
Like EDV. So unless they're protected from sun, at what age will this child die? 20s, 30s, if they're lucky. With sun protection, they can live a normal life, but without sun protection, they'll die about the same age that someone with xeroderma pigmentosum would die of metastatic squame. So those blue foamy cells, the coarse basket weave, all go with epidermal dysplasia versiformis. Very good.
So, looks like a nevus. or something.
Yeah, looks like a nevus. Anything else we should know about this patient besides the nevus?
Oh, do they have scabies?
They have scabies.
Scabies and
Yes.
EDVs.
So it's a twofer. The nevus was taken off as a nevus. Are you itchy by any chance? There are scabs up in the horn.
So there's a deeper infiltrate. I'm going to tell what type of cells those are.
So there's some neutrophils here, but what's going on there?
Deposit of something.
That used to be fat.
Okay. So is it like a paniculitis, like pancreatic?
Like pancreatic paniculitis. And so you hope your patient has gallstones, right?
Yes.
Because if they don't have gallstones, what do they probably have?
The tumor. in the
Pancreatic
pancreas.
cancer. What's the biggest, to one of the DermPath fellows, what is the most important simulant of pancreatic paniculitis histologically? Yeah, mucor. So you can get paniculitis like fat necrosis surrounding mucor. So pancreatic paniculitis versus systemic mucormycosis, big difference. So you want to make sure anytime you see pancreatic fat necrosis, you want to look closer and make sure they're not mucor hiding in there.
Delayed.
Didn't look like much at scan, did it? It's one of those that makes you break into a cold sweat. Right? So what do you see there?
Okay, that's not supposed to be there. Not sure.
So round to oval forms, in fact so many of them all through the dermis that you almost don't see them at first, right? Because they're everywhere. And are they sitting by themselves or are they sitting together within a clear space?
Within clear space.
So anybody? Crypto, systemic cryptococcosis, right? Round to oval pleomorphic yeast. So most fungi, everyone is the same size and shape as the next one. Crypto, they're all different in size and shape. Round to oval, and they, instead of liking single family houses, they like apartment living, right? They're all together in their gelatinous condominium. How are we doing time-wise? Got about 10 more minutes.
Looks like we have a subepidermal bulla.
Subepidermal
I
bulla
would think BP.
filled with EOs, so could be BP. Name two other things it could be.
It'd be like bullous arthropod.
So bullous arthropod, especially bullous scabies. What else simulates BP?
EBA.
EBA. And then EBA are the ones that are refractory to treatment, often tumor associated, all of the extra baggage that goes with something that looks like BP but isn't actually BP. Yeah, it looks, so you have a flask-shaped vesicle. I don't see a lot of Langerhans cells in it, but certainly that shape goes with the Langerhans cell microabscess of a spongiotic derm. So there's definitely spongiosis, but within the spongiosis you have lots of eosinophils. So what can give you spongiosis with eosinophils? Anyone? How do you feel when you see spongiosis with eosinophils?
Happy.
You feel happy, happy standing for herpes gestationis,
That too.
arthropod, allergy, pemphigoid, pemphigus, incontinentia pigmenti, and this is another pemphigoid at a spongiotic phase, but spongiosis with eos. So your happy differential, and then erythema toxicum. Let's see. This is a good one.
So, quite a bit of information. Almost clustered.
Quite a bit of inflammation, and then also,
The vessels too.
and tell me about the endothelium.
Hobnail.
Hobnail endothelium, and you said the words quite a bit of inflammation.
Yeah.
Put that together. What do we have?
The hobnail hemangioma.
So hobnail hemangioma would be targetoid hemosiderotic, but what is the other hobnail?
Is it the angiolymphoid?
ALHE. Exactly, angiolymphoid hyperplasia with eosinophilic. Well done. Pass that easy button. HPAP. A little slow, but good. So, pass the easy button to Manuel. So HPAP is the maze you can hide in as opposed to SPAP, which you can slide into.
How to check the HPAP versus erosive
Adenomatosis of the nipple. So intraductal papilloma or erosive adenomatosis of the nipple is essentially HPAP in the breast.
Oh.
So it's essentially the same thing, right?
So
It's just nipple adenomas and HPAP in the duct.
Background of the smooth muscle.
Background of smooth muscle, background that would suggest that it's breast. But it's basically the same thing. It's a papillary adenoma of the lactiferous duct, just like an HPAP. The one you have to be careful of is what if you had this on a digit? Aggressive digital papillary adenocarcinoma. There, for all intents and purposes, are probably no benign adenomas on the finger, right? If you see something that looks like an HPAP with solid areas on a digit, it's going to behave like carcinoma. So mixed horn, there are newts in the horn, right? Does it look like a psoriasiform epidermis though?
No, it doesn't.
It really doesn't. So there are newts in the horn, no psoriasiform epidermis.
It could definitely be tinea.
So it could be tinea. I see both sponge and interface.
Could be viral.
Drug viral. What's the other one that goes in? Is that syphilis, especially with newts in the horn? This one was called pityriasis lichenoides. I mean, it's not quite as dirty a scale crust as you expect for that. There is some interface, but there's also sponge. So I would definitely think of drug viral syphilis. And you have something that looks like pityriasis lichenoides that can be syphilis also. So I would be cautious about that. And let's do one last.
Gout.
So gout is definitely a possibility.
Tcell.
Eruptive xanthoma, well done. So you can see the xanthoma cells surrounding those crystals. And the crystals are a bit large. Gout is really fine feather-like crystals, whereas this are larger crystals like eruptive xanthoma. So pass the easy button over here, and well done.
That was easy. Rien de plus simple.
And we're done for the morning for those online.